to another one of our Whole Person Care webinar series. I am Dr. Holly Luteal. I am a licensed naturopathic doctor and senior medical advisor here at Fullscript, and I am so happy you've joined us today. All right, so the focus of this webinar, I'm so excited. I'm always excited about our content, but is optimizing hormonal balance. What a topic for our modern day. In our first session, we're going to focus on mapping the fluctuations of estrogen and progesterone throughout a woman's menstrual cycle using a Dutch cycle map. And leading today's session, next slide, is Dr. Brooke Ottman. She is a licensed naturopathic doctor and clinical educator at Precision Analytical. And before we get started, again, just a few quick housekeeping notes that I will repeat throughout the session today. You can submit your questions in the chat and we'll address as many as possible after the presentation. If we don't get to them, we're going to get them answered by hook or by crook, okay? And then also, of course, the webinar will be recorded and a copy of the presentation and the slides are going to be available for download in the files section of the webinar platform. And thank you again for joining us today. So happy to have you. And I'm just going to let Dr. Ottman take it away.
So, of course, our disclaimer that this presentation is for educational purposes only and is not offering any clinical or medical advice. So to go over our learning objectives for this webinar, we are going to be doing a quick review of the phases of the menstrual cycle. We'll cover how to use a Dutch cycle map and how to use it to monitor a menstrual cycle. We'll look at some case examples of both normal and abnormal menstrual cycles with a cycle map. And then there's just a quick review of some therapeutics that support each phase of the cycle, and then we'll have a little bit of time for a question and answer at the end. All right, so let's dive into just this quick review of the menstrual cycle. So a menstrual cycle, typically we think about 3 phases of the menstrual cycle. An average cycle is about 28 days. Cycles can be longer or shorter, 21 to 35 days, and are still considered normal if they're regular. But for most purposes throughout this presentation, we'll be talking about an average 28-day cycle. So that follicular cycle is the early phase of the cycle. It's typically cycle days 1 through 13. We have a single day of ovulation, typically around day 14. And then we have the luteal phase following ovulation. Typically that is cycle days 15 through 28. So again, cycles can be shorter or longer. A lot of times we'll see shorter in younger women, longer in older, but it is highly individual. So a little bit more review and depth of those different phases. So that follicular phase early in the menstrual or early on includes the menses. So day 1, cycle day 1 is the first day of bleeding. During this phase, the follicular phase, the next egg is getting ready to mature and release. We see pretty low levels of estrogen and progesterone during the follicular phase, although estradiol does begin to rise around day 7 and it reaches a peak around day 14. So that leads us into ovulation, which again happens around day 14. We see a strong estradiol surge that signals for luteinizing hormone release, which in turn triggers ovulation. That usually happens within about 24 hours of that LH surge. Following ovulation, we have the luteal phase. This is typically going to last about 14 days. At this point, the egg is ruptured from the follicle, leaving behind a corpus luteum, which produces progesterone. The estradiol does drop from the ovulatory surge, but it stays slightly elevated with the progesterone to help support the endometrial lining. If no pregnancy happens, then we see a decrease in progesterone and estrogen, and this causes an increase in prostaglandin levels that cause uterine contractions and, in turn, the uterine lining to shed. This then leads to the menses and the start of the next cycle. So let's go into looking at like what our Dutch cycle map looks like here. So, the cycle map is an assessment of estrogen and progesterone levels throughout the entire menstrual cycle. We're trying to get a picture of what's happening throughout all those phases. If you see here plotted out, we see a lot of like rises and falls. And so, if you test at one point in the cycle and then test a week later, you're going to get things that look very different. So, testing cycling female hormones require a little bit of forethought. So this gets us a little bit into who to test and what a whom a cycle map might be appropriate for. So we would test people potentially with regular cycles, irregular cycles, and sometimes patients without a bleeding cycle that are still potentially hormonally cycling. So that might include someone with a progestin IUD or with a hysterectomy where the ovaries are still intact. Some great times to test is when we do have irregular cycles, when there's perimenopause, or when there's symptoms at certain times throughout the cycle. So, fertility concerns, migraines, mood swings, spotting, breast tenderness, all of these can be great to look at the different hormone levels and fluctuations, both at the time of symptoms as well as what's happening right before those symptoms appear. We don't necessarily recommend the cycle map for all patients. There's some ones that where a single day collection may be a better option. So if a patient has not gone through puberty and has not had a menses yet, we wouldn't recommend a cycle map. Once they've entered menopause, either surgical or natural menopause, they're no longer hormonally cycling, and so we wouldn't recommend the cycle map. We also don't recommend it if they're on oral birth control, especially those combination pills. It's not recommended to diagnose menopause, and it's not used to monitor hormone replacement therapy. These in these cases, there's no hormonal cycles, so every day looks very similar. So a single 1 day collection is a better option. So we can test these hormones, estrogen and progesterone, in serum, but it's unlikely we're going to want to map out an entire cycle in serum because we'd have to be sending a patient for a blood draw every few days. So in serum, if we're looking at estrogen and progesterone, we tend to pick two times. Early in the cycle, like around cycle day 3, when we expect estrogen and progesterone to be low, and then again, potentially around cycles day 19 to 21 when we expect more robust estrogen and progesterone. That's also when we would want to look at an estrogen progesterone balance. Alternatively, with the Dutch cycle map, you get that hormone information throughout the cycle, and it takes the guesswork out of when are those you're going to target those kind of times. So we get information from the entire cycle, plus it's easy to collect at home and you get a little bit more information. So, why might you test? We've gotten into this a little bit, but we want to be able to identify the different cycle phases and also that timing relative to any patient complaints. We're really looking at trends over time versus that single day hormone look. So you can see here, this is a really great example. This is two different patients, both with a 34-day cycle. If both of them had collected for a single day, about 5 to 7 days before menses, they'd look exactly the same. Like, look at day 27 for both of them. It's circled here in their 34-day cycle, both very low. But you can see the cycle map is a completely different view for both of those. They're both anovulatory. We don't see any rise in progesterone, but the one on the right is developing follicles and having an estrogen cycle, while the left is not showing any follicular activity. And so this could also drive very different treatment plans for each of those patients. So we can get a little bit more into using a Dutch cycle map. And in part, I want to start with how we collect a cycle map. So there are some pretty clear instructions included. We do have three options for collection: a normal or short cycle, so anything 34 days or less, a long cycle, which would be more than 34 days, or a no cycle. So again, someone that's maybe had a hysterectomy, an ablation, or an IUD. We have those kind of this have them collect starting usually around day 7 if they're cycling, and then they collect every few days. This collection schedule is nicely mapped out there. You can see that on the right, an example of that. From all of those collection samples, the lab pulls 9 different days of data that will represent each phase of the cycle, so we get a good picture of estrogen and progesterone in all 3 of those phases. They do also list when their next menses starts, and then they do a 4-sample collection, typically around day 3, 4, or 5 after that next menses, that provides the early follicular data, as well as it also provides samples for looking at like the cortisol and organic acids if they've ordered any additional panels with the cycle map. So that's how that all works for on the patient side for collection. So let's take a closer look at a normal cycle before we dive into maybe what some unusual cycles might look like. So I did bring some fun ones to take a look at. So this is what it should look like. So we have across the X horizontal axis is listed our cycle days. That Y vertical axis is the result. Each dot is representative of one of those days of collection. And then we plot it out to kind of track that trend over time through the phases. Between the 2 gray shaded lines, that's considered the normal expected range, again, for a 28-day cycle. And then the colored dots and lines are the patient's actual results. So, a little bit of note about measuring hormones in urine. You'll see on the cycle map that we use beta pregnanediol as the surrogate marker for progesterone output. That's because we don't really pee out progesterone, we pee out the progesterone metabolites, alpha and beta pregnanediol. The beta pregnanediol you can see correlates really nicely with that serum progesterone at all points in the cycle. We have that comparison listed out on that top right graph where we've plotted urine beta pregnanediol compared to serum progesterone throughout a cycle. And then it's the same thing with urinary estradiol. Sometimes providers like to use estrone as an additional surrogate for serum estradiol, and that can be consistent with other studies. So we do have estradiol and estrone on the cycle map. But if you look at the comparison of serum estradiol to urinary estradiol, again, those correlate really nicely throughout the cycle. And so that's really looking at that graph on the right-hand side, plotting those against each other. And this data is from one of our published papers that's included in the references at the end of this presentation. So I mentioned that there are 2 progesterone metabolites. Beta pregnanediol is the more predominant one, and that is the one that we use to correlate with peak progesterone. Beta pregnanediol is also all over the medical literature as that big correlate with progesterone levels. But you are starting to see some alpha pregnanediol research and information emerge, particularly around PMDD. And then the other thing that's worth noting is it can be an additional measure of 5 alpha reductase activity. So in cases of like PCOS, it may be 5 alpha reductase is affecting androgens. It can affect mood regulation and be a sign of insulin sensitivity and inflammation. So alpha pregnanediol can be a marker of progesterone production, but it's also a marker of 5 alpha reductase activity. So again, this gives us another dimension of information on the cycle map. All right, let's start taking a look at some cases here. Again, we're going to kind of start with looking at a normal case. I've highlighted kind of our peak times. Cycle day 14, we have that peak estradiol. Cycle day 21, we have that peak beta pregnanediol. We have those cycle maps plotted out in the top, and then we do have all of the measurements listed out in that chart below. So you'll see the sample number listed across the top, followed below that by the day of the cycle that correlates with it. And then below those are the estrogen and progesterone metabolite measurements. So you'll see I've highlighted that sample day or cycle day 14 and cycle day 21 are circled down in that chart. One thing to note is that we will highlight the peak beta pregnanediol day as our peak luteal day. That is the day that all of the estrogen progesterone information would be pulled into any additional Dutch testing that was ordered, like a sex hormone panel or Dutch Complete or Dutch Plus. It's also the day that you're going to want to look at the estrogen progesterone balance if you're interested in that, because that is where we're seeing peak progesterone. All right, so things are getting a little bit more interesting here. This is a 46-year-old who's had her uterus removed, so she's no longer having bleeding cycles. You can see here there's actually fairly normal estrogen and progesterone, but because we don't know where she is in her cycle when we started the collection, the pattern is a bit shifted to the right. And it actually looks like we caught two luteal phases here. So when we come in that first day of collection, we're already in that luteal phase. It looks like it peaks by that second collection, drops down through the follicular phase. You see that estradiol rise a little bit later, and then you see a second progesterone rise in a second luteal phase that we've plotted out here. And that's really due to the timing, but it was cool that we got to see two cycles there. So this one is a 50-year-old with regular cycles and perimenopausal symptoms. So you can see very clearly here there's some estrogen dominance over progesterone in that luteal phase, which can be very typical of perimenopause. The beta pregnanediol is barely getting into that luteal range by the end of the cycle, whereas estradiol is more running towards the upper end of range through that luteal phase. The other thing that's interesting is we see that high day 4 estradiol level, and that could be a marker that may suggest diminished ovarian reserve. So we do see that in older, later perimenopause patients. You also get to see why she's cycling regularly. She's got all of those elements that we've been talking about. She gets that surge of estrogen pre-ovulation, and then she does ovulate and get a rise of progesterone. So ovaries are hanging in there on their way out, so levels are suboptimal compared to our younger cycling patients that we've seen in some of these earlier normal cycle maps. She also may be feeling this roller coaster a lot more because there is a lot more estrogen throughout the cycle. Potentially, there's more bleeding or spotting, mood swings, breast tenderness, and hot flashes from those highs and lows of estrogen throughout the cycle. So this one's one that people always love to see. So this is a 31-year-old who's taking fertility meds. She's taking 100 milligrams of Clomid, cycle days 2 through 7. There we don't necessarily have any expected ranges for someone that's on these therapies, but this is what we would expect it to look like. So we see early in that follicular phase, her estradiol and estrone levels have soared way past their normal ranges. And in fact, that y-axis had to expand, kind of squishing down the normal range to be able to accommodate the levels. Typically, that ovulatory estradiol range tops out around 12, and she's probably close to 4 times that here. Again, this is an expected effect of the medication. She's recruiting a lot of follicles, so we can see it doing what it's supposed to be doing. We can then see that the estrogen settled down to fairly normal luteal ranges after ovulation has occurred. And then she gets a really nice, robust progesterone level, maybe even a little bit high normal, which again is to be expected post ovulation with these fertility meds. So it doesn't look like she got pregnant this cycle. If she had, what we'd expect to see is that estrogen and progesterone would surge upwards from that luteal phase instead of dropping down like we see here. So this one's a 25-year-old with a Mirena, so on a hormonal IUD. She's not cycling, but she felt like she was having some symptoms that correlated with a cycle. So we went ahead and took a chance, had her do a collection, and you can see that she is cycling hormonally, even though she's not bleeding. When we do come in on day 1, again, the pattern here is a little bit shifted because by that first day of collection, she's already at that pre-ovulatory surge of estrogen. And then not too long afterwards, afterwards, by about day 10, she's already in that mid-luteal peak time. So something to note is those IUDs are really acting locally on the uterus, thinning the endometrium and changing cervical mucus to achieve birth control. But it mostly leaves the ovaries intact, still functioning and developing follicles and ovulating like they normally would during a menstrual cycle, even though they're not having that bleed. So this is a really good example of getting to see that happening. All right, so here we have a 38-year-old who's having constant bleeding. Wanted to see why that might be. You can see that there is lots of estrogen consistently throughout the cycle. We never get any rise in progesterone. So really an anovulatory picture. Ended up that she had endometrial hyperplasia. Obviously, there's a lot of estrogen around and unopposed estrogen, so that likely was a contributor to that hyperplasia. And then here we have a 27-year-old with amenorrhea. Wanted to see if anything was happening since she wasn't getting cycles. We can see really nothing happening, right? Low estrogens, low progesterone, no ovulation. She's not hormonally cycling. When we see something like this, the next step would be like trying to figure out the root cause, like what's going on, why aren't ovaries cycling in this young female? All right, and then I'm going to leave you here with just a few treatment considerations targeted to those different phases of the cycle. We can notice that many of them are antioxidants and mitochondrial supports. We do need normal hormonal activity from the adrenals and from the thyroid, good tissue conversion of T4 to T3. We need those fat soluble vitamins and minerals. And then something to keep in mind is all the work that you do in that follicular phase will come back and pay you back in dividends kind of during that luteal phase because we have a much stronger and healthier corpus luteum. All right, so I'm going to say thank you and we're going to move on to that question and answer time.
All right, I am back. Thank you so much for that. Excellent. Okay.
Yeah.
Couple questions here. Can you do a cycle map while a patient is on hormonal contraceptives?
So we kind of touched on that a little bit earlier, but most of those combo contraceptives are suppressing ovarian output and preventing ovulation. So we're not going to get hormonal fluctuations. And so it's just really not worth taking a look at it because we're just going to see kind of like our amenorrhea patient, pretty low levels throughout that cycle, even though they're having a withdrawal bleed, not really a menses
Okay.
there.
What do you think then, doctor, would be the best test for a patient on birth control or HRT?
Yeah, so that's where those one-day tests are gonna be sufficient because day to day, they're not having fluctuation. So you could check levels in serum, you could do something like a Dutch Plus, Dutch Complete, where you get to also look at the hormone metabolism, which can correlate with a lot of symptoms too, but a one-day view is gonna be sufficient for those patients.
Okay, great. And then, okay, so will you re-explain just succinctly that case with the IUDs?
So when patients have those like the progestin containing IUDs, a lot of them are having irregular cycles or no cycles. And it's more because of the local action where they're not building up an endometrial lining versus their ovaries are still cycling. Like they're still getting estrogen, progesterone fluctuations from their own ovarian output. So it's very different than like an oral contraceptive. The tricky part is you don't know where in their cycle they are if you wanted to do a 1 point collection. So that's where a cycle map can be really helpful. So you get to see, are they cycling?
Okay, excellent. And then on that, can you explain the different types of hormone metabolite tests done by Dutch? Like, obviously, we just talked about the cycle map.
Mhm.
Specifically, is it worth to add the Dutch Complete? I mean, I love that test in
Yeah.
particular. You get so much
Yeah.
for the big bang for the buck. But
Yeah.
yeah, kind of break it down. Just we got about a minute left, and then we'll get those other questions answered for people in other ways. But yeah, do that for us. Just explain the different
Yeah.
types.
Yeah, we have a couple we have the Dutch Complete, which is probably our most commonly ordered. And the thing that you're going to get there is you're going to get androgen information, you're going to get estrogen metabolism, which can be really important to know. You're going to get adrenal information and organic acids. And it's really nice. You just get so much more information. And when you pair it with the cycle map, again, it takes the guesswork out of finding that luteal peak because we're going to already have determined that. We pull that estrogen progesterone over. That's kind of our main test. We do have like the Dutch Plus, which adds some salivary cortisol to it, which can be helpful with insomnia or like a lot of stress. Or you can break out any of the panels. Like if you just want to look at sex hormones and that metabolism, you can do that, or the adrenals or the organic acids. But I'd say the Dutch Complete paired with the CycleMap is really one of my favorites for women that are cycling.
Yeah, you get a lot of information there,
You
and
get so much information. Yeah,
a
it's
lot of
great.
guidance. All right, Dr. Oden, thank you so much. And all of you, thank you for attending and participating in this particular session today. If we didn't get your questions answered, like I said, feel free to reach out at info@dutchtest.com. We are now going to take a 5-minute break. However, I do encourage you to stick around. Our second session, the role of saffron, chromium picolinate, licorice extract, all of those things in managing mood, sleep, digestion, and food cravings. And this is presented by Melissa Carullo, and it is definitely a fantastic follow-up for what we've covered so far. So 5 minutes and we'll see you back here. Thanks so much.